What's up, good people? Welcome back to my channel, and in this video I want to talk about a very common condition which happens mostly in majority of the young population. It's called herpes simplex infection of the eyes, and it can happen to other parts of the body also, but because it's my specialty being an eye doctor, so I wanted to bring it forward to the audience attention that yeah, it's something that exists there. If you have those symptoms, get back to your eye doctor ASAP. Okay, so let's go over it. So this is how it can look like. It has multiple presentations. It can be as simple as a pink eye, or it can be as worse or as bad as something like this that you see in the top left or the extreme left picture. It can be a really bad presentation, and it can end up into something like corneal transplant also in certain scenarios. So it depends on patient to patient, so you don't have to take it too lightly. That's my point. Okay, let's go over it without any further delays. Symptoms, how does it present? So you need to know about the symptoms and the signs of this condition, and that's how you will be able to reach an eye doctor, and that's how you will be able to reach some sort of treatment plans about it. Painful red eye, that's one of the most common presentation, and that's one of the most initial symptoms that you will see. Painful red eye that will happen to you or somebody with this condition. And sometimes you have all of these symptoms, sometimes you have some of these symptoms. What are the other symptoms? Foreign body sensation, itching, the eye is quite itchy, red, watery, decreased vision also sometimes. Like if you compare between the two eyes, you can tell that this eye that has a problem going on is not seeing as clear or as crisp compared to the other eye, the good eye. Okay, in addition to that, you have some vesicular rash, as you can see in this picture here, that there is a vesicular rash at the eyelid margins, at the eyelid itself. The skin part basically gets those vesicular rash. It could be the orbital skin, periorbital skin, the lid skin, all that. Usually it's unilateral, which means it affects one eye. Okay, so it is sometimes bilateral also, but not always. And sometimes you have a history of previous episodes also with the similar problem. What are the signs? The vesicles that you see in this condition, they are clear vesicles with an erythematous or reddish base. The vesicular rash at the eyelid or the orbital skin will have some sort of crusting at any stage of this disease. Okay, it depends. Sometimes the crusting is so less that you kind of don't even notice it, but vesicles with an erythematous base are the most common presentation with it, with some redness in your conj. The white part is called conjunctiva, that becomes injected and red and inflamed. Usually, as I mentioned earlier, it's unilateral. 90% of the times it happens to one eye only, but 10% of the cases can have it in both eyes. So know about that. And there is sometimes the history of previous episodes also. Macropunctate keratitis, that's one of the signs of this condition, with dendritic keratitis or geographic ulcers can also be seen in this kind of herpetic simplex virus infection. Heaped up edges, when you are examining this under slit lamp, you will see the edges of those dendrites. They are heaped up, they are bunched up, and you can literally notice, as you can see in this picture also, that the edges are heaped up, that they're crunched together. And epithelial keratitis that stains with rose bengal or lissamine green is very, very definite or diagnostic of this condition. In addition to that, you also have central ulceration into it sometimes, but not always. You can have it, but not always. It depends on the stage also. Central ulceration stains well with fluorescein. And one of the diagnostic signs in the clinic that you can do very quickly is corneal sensitivity testing. With the corneal sensitivity testing, you can tell that if the corneal sensitivity is reduced, that's another sign that, okay, it's herpetic. It's herpetic and not bacterial, because the corneal sensitivity is not reduced in the bacterial keratitis, but in herpetic it is. But remember, when you are testing for that, do not put the numbing drop or staining drop, because many staining drops also have the numbing effect. So do it before you do any of those things, okay? Differential diagnosis. Well, with the differential diagnosis, you need to know that other hepatic infections also exist. One of the most common ones in the other hepatic infections is herpes zoster or varicella zoster virus infection that has the pseudodendrites, which has the slight elevation to it without central ulceration and do not have terminal bulbs and do not stain with fluorescein. So that's how you differentiate between zoster and simplex virus infection, about those staining things and those appearance things that I just described. Another thing to remember is sometimes it could be RCE, recurrent corneal erosions, or recent corneal abrasion. RCE or recent abrasion, they are two different entities of the corneal conditions. They both can resemble herpetic simplex virus infection. A healing epithelial defect has a dendritic appearance. So you never know. It could be just an epithelial defect that is healing in a corneal, infection or anything that happened, for example, to a contact lens wearer. So you need to decipher between those things. And RCE with lattice dystrophy can have similar presentation. So you need to be aware of those things, because if you are not, you can end up into problems and over-diagnosing and over-treating. Acanthamoebic keratitis is another condition that can have pseudodendritic appearance, but it's a bigger problem that you should not be missing. Ask a lot of questions to the patients because history is important. Stromal keratitis, another presentation of this condition. Stromal keratitis is an important thing to be aware of, to look for it, because once you have the stromal keratitis, you are in a bigger condition zone. You are in a big zone to treat and involve the cornea specialist, because stromal haze is something important. Stromal haze is dangerous. Stromal haze could be unifocal, could be multifocal. You can have stromal edema in the absence of corneal ulcerations. If it is vascularized stromal keratitis, that means it has been there for a long time. That means it's chronic. So be aware of those things. Be watchful of those things. Stromal keratitis with and without ulceration, they are different. Without ulceration is any interstitial keratitis, but with ulceration, if it is ulcerated, if you see the ulcerations over there, that means necrotizing keratitis, which would have a suppurative stromal inflammation, thinning with an adjacent or overlying epithelial defect. Okay, know those words, they are important and you have to be watchful of those. And now comes the deadliest part, where you have to have a cornea specialist. I don't really, go that far with my patients. I bring cornea specialist into the game, into the treatment plan. If the patient has stromal and epithelial edema of the cornea in round or discrete patterns with stromal and epithelial edema in the cornea part, or discrete pattern with keratitic precipitate, sorry about the tongue twist, KPs. In short, I call it KPs. If you have those KPs going on out of proportion to the interior chamber inflammation, that means you are in a danger zone called endothelial keratitis or disciform keratitis, as shown in this picture right here. That's not good. That means your patient is getting serious. You need to take it seriously. You need to involve the other members in the teamwork, other MDs. Neurotrophic keratitis is one of the other presentations that can happen, as shown in this picture. Uveitis, retinitis. These are the red flag conditions that you have to have serious treatment plans and serious teamwork going on there, and the patient needs to be very much aware of those things. What workup would you do if you have a patient like that in your office? What workup would you do? I usually start with slit lamp exam. This is the slit lamp as you see in the picture. I start with that slit lamp exam, intraocular pressure checking, corneal sensitivity testing, and external eye exam of the skin, periorbital skin, unilateral, bilateral. Just rule them out. Look at the vesicles, look at the pattern of the vesicles. Make sure you dilate your patient in the same visit or in the follow-up visit. You have to make sure you have dilated at least once to rule out any of the dangerous conditions like I have in this picture here, the retinitis. You cannot ignore that. You cannot ignore uveitis. You have to make sure the back of the eye is healthy. So dilate your patients. It's important. Other testing that I don't do, some doctors do, are PCR, Giemsa staining of the cornea or the vesicular scraping. This HSV titers of the antibodies of the HSV, they can help you in conditions. For example, if you have acanthamoeba suspicion going on and you're not sure that, okay, this is definite herpetic simplex or not, these testings, the PCR, HSV antibody titers or the corneal scrapings to go for the labs, they come into role in that kind of scary differentials that you want to make sure that you know what you're treating and you know what you're not going to treat. Okay, that's where the workup is important. Now comes the treatment. Treatment is a bit different depending on the level of the condition, the severity of the condition, the duration of the condition. So let's say if the treatment is only for the skin part and the eye has not involved to the corneal extent, you only see the skin is involved and the white part is only involved, which is the conjunctiva. Usually at that level, it is self-limited. Treatment can help shorten the course of the disease and reduce the corneal exposure to live virus. So that's why many doctors, including myself, we start at certain things. For example, there are 3 antivirals that you can start per oral medicine. They are acyclovir, valacyclovir, and famciclovir. They have different dosages and different time durations as mentioned. So you can go with any of those. Or if you don't want to start oral antivirals, you can have topical, the drop forms or the gel forms of other antivirals. For example, topical Cyclovir 0.15% is a gel form, ophthalmic gel that you can give 5 times a day, or trifluridine 1% that you can give 9 times a day for 7 to 10 days depending on the severity. Okay, but let's say if the cornea has started to get affected, then you can again either do the topical, the drop or gel form, or you can do the systemic, which is the per oral antivirals. And when it comes to that, you need to know what level of severity is the epithelial keratitis at. It would be at 2 levels. It could be either just dendritic or it could be geographic, and in either case the treatment plan is going to be slightly different. If it's just dendritic, you can start per oral treatment with acyclovir 400 milligram 5 times a day, or valacyclovir 500 milligram 2 to 3 times a day, and famciclovir 250 milligram 2 to 3 times a day for 7 to 10 days. Or you can do the topical ones, the Cyclovir 0.15% gel, or acyclovir ointment, which is 3% 5 times a day, and for 7 that you do for 7 days, and trifluridine 1% drops, which we will be doing for 9 times a day until it is healed, and then we do 5 times a day for 7 days. So do not exceed beyond 21 days unless until absolutely needed or indicated by the cornea specialist. If it is a geographic one, then again the treatment plan is a bit different as shown in this picture, in this slide, and I tend to add cyclopentolate 1% 3 times a day or so, because let's say if the patient has AC reaction, anti-chamber reaction, and there is a lot of light sensitivity and pain going on, I give it a try. I give it as a pain thing. And also patient can take oral pain medicines, whichever one they prefer, like Tylenol or Motrin and stuff like that. Okay, suspect bacterial infection or acanthamoeba keratitis if the treatment does not work for 1 to 2 weeks. By that time, I've already decided that, okay, I'm doing something else, because I watch very closely. I have more frequent follow-ups for this kind of patient. Well, if it's the stromal keratitis, if the thing has gone beyond epithelium, then comes the role of steroid, prednisolone acetate. But remember, it's stromal keratitis without epithelial ulceration. So you can do 6 to 8 times a day, and you taper it slowly, 1% pred acetate. Prophylactic antivirals, as you know, shown in the slide with different dosages, can also be added, and yeah, I go with that as well. You know what, if the treatment for HSV stromal keratitis is there and you are seeing the epithelial ulceration, then you are doing prednisolone 1% 2 times a day, tapered slowly. Okay, so it changes a little bit. You do it twice a day and you taper it slowly, whereas when you were doing the stromal keratitis without epithelial ulceration, you did the steroid for 6 to 8 times a day, and with the prophylactic antiviral dosages shown here. But again, here in this regard, when there is ulceration, you reduce the number of times that you will be doing the steroid, the pred acetate, but you still have the oral antivirals as shown in this slide. And then you have to follow up with this patient. I follow up very closely. Every other day I follow up with them, 2 to 7 day follow up with them, depends on the severity. So you have to follow up to evaluate for the response to the treatment, and then once you start seeing the response, you do 1 to 2 weekly follow-up depending on the clinical appearance, clinical picture of that patient. And at follow-up, every time I have that patient, I am looking for the size of the epithelial defect and the ulcer and the corneal thickness and the depth of the corneal involvement and tear chamber reaction and intraocular pressure. All those things are very important. AC reaction, intraocular pressure, corneal appearance, the dendritic appearance, if there is any geographic ulceration, or if there is any stromal involvement or not, if there is any neovascularization or not, what's the corneal thickness, what's the epithelial defect like, and all those things. They are extremely important at every single follow-up. They are serious patients. Patients with necrotizing keratitis need daily follow-up, and sometimes they even need hospital admission, especially if there is a threat of perforation, because if the cornea gets perforated, that's a scary thing. Okay, you don't want that. Some patients, they end up with corneal transplant as well. If inactive post-herpetic scars are significantly affecting vision, but before going to that route, we should try RGPs. Many doctors, they try gas permeable contact lenses and maximize the aggressive lubrication, and the eye should be quiet for at least 3 to 6 months prior to the surgery, which is the corneal transplant. So you need to do those things before you get into the surgery, the corneal transplant. That's a big surgery, so you have to prepare your patient accordingly. Okay, what to do for long-term oral antiviral prophylaxis? If patients have, when to do it, when would you do it, and what to do about it? If the patient has multiple episodes of epithelial disease or stromal disease of herpes simplex keratitis, then you do it. That's when you do the prophylaxis, and the prophylactic dosages are a little bit different. They are shown in here that, okay, you do the acyclovir 400 milligram 2 times a day, or valacyclovir 500 milligrams 1 to 2 times a day, or famciclovir 250 milligram 1 to 2 times a day. But you do it and you follow up on those patients.